Good afternoon, and thank you for joining us for today's webinar. We will get started in just a few minutes. While you're waiting, please take a moment to provide your name and organization in the chat box located on the lower left-hand side of your screen. Our webinar will begin shortly. Good afternoon, and thank you for joining us for today's webinar. We will get started in just a few minutes, giving a few people a chance to get logged in. Good afternoon, and thank you for joining us for today's webinar. We will get started in just a few minutes. Good afternoon, everyone. My name is Eric Bix, and I'm the Director of Government Affairs here at National Council of Urban Indian Health. Thank you for joining us today for this webinar entitled Sponsorship of Urban Indian Health Clinic Patients in Marketplace Coverage. The National Council of Urban Indian Health is a membership-based nonprofit that represents 43 urban Indian health organizations across the nation that provides essential health and social services to American Indians and Alaska Natives living in urban settings. If you have not already done so, please type your name and organization in the chat box located in the lower left-hand side of your screen. All lines are currently muted. If you wish to ask a question, please place the question in the Q&A box located in the lower part of your screen. There will be time for Q&A throughout the presentation and at the end. Today's webinar will be presented to you by Daneg McDonough. Daneg McDonough leads the health care consulting firm, Health System Analytics, and advises clients on maximizing opportunities under the Affordable Care Act, the ACA, and the Indian Healthcare Improvement Act, or ICHIA. Daneg serves as a technical advisor to the Tribal Self-Governance Advisory Committee, the IHS, where he in part reviews federal regulatory developments involving CMS, the Indian Health Service, and other federal government agencies implementing the ACA and ICHIA. Daneg also serves as a technical advisor for the Tribal Technical Advisory Group, or TTAG, the CMS. For the past 4 years, Daneg has been engaged in assisting tribes with maximizing insurance coverage and revenue opportunities, such as implementation of tribal sponsorship programs. Daneg previously worked for state government on health and social service program management, as well as the national health policy as a congressional staff member. We are very excited to have Daneg with us today. Before we begin the presentation, for those just joining us, all participants are currently in listen-only mode. We ask that you place all questions in the Q&A box located in the lower portion of your screen so they can be answered throughout the presentation. Please note that the presentation slide is available as a PDF located in the lower right-hand corner of your screen. I will now turn it over to today's presenter, Daneg McDonough.
Thank you very much, Eric. It's a pleasure to be on here. I appreciate the opportunity to make a presentation today. And as you indicated, we'll have 2 or 3 breaks in the presentation where we'll field questions so that we can answer questions sooner than later. So let's go ahead and dive in. This opportunity is going to be helpful to me as well to hear issues on sponsorship, which may be specific to urban Indian clinics and their patients that might have a bit of a variance from other tribal health programs. So I look forward to having a discussion about differences that may be there and maybe modifications to approaches to sponsorship for urban Indian clinics. So let's dive in. So we'll go through an overview of tribal urban Indian health program sponsorship through the health insurance marketplace, talk about different approaches to sponsorship, talk about the opportunities and also the requirements under the Affordable Care Act, modeling that's been done on options for structuring sponsorship programs, some examples of net financial impact on tribal programs. I have not yet done an evaluation of any urban sponsorship programs, but that would be something very much of interest. I would like to be able to share that information for folks as well. And then we'll go into some specifics about the establishment of sponsorship programs, some of the administrative considerations that folks might have. Some resources that are available, as mentioned, I'm a technical advisor to the Tribal Self-Governance Advisory Committee. On the website of tribalselfgov.org are a number of materials related to sponsorship, and there are a few links here that go to some specific items. The first being Fast Track Key Tasks. There's a list of 10 tasks that are needed to set up a sponsorship program, and so may help guide you through there. There are also set up links to other materials that are helpful in accomplishing the different tasks. The next link there is overview of briefs, or overview of webinar and sponsorship is linked there. Next are a couple briefs. I just want to point out the first one there that's referred to as applicable percentages. What that is under the Affordable Care Act, there are a whole bunch of metrics and reference numbers and eligibility criteria and what have you, such as what's the federal poverty level for the marketplace for Medicaid, and those differ sometimes of the year. What's the percentage to define affordability? what's the amount that an employer has to pay if they don't offer coverage. All those kind of things are listed in that applicable standards brief and are updated regularly as IRS and HHS update the numbers for each year that goes forward. There's also a couple examples from other tribe-specific presentations on sponsorship that are shown on the website. So to the basics of it, what is sponsorship? Tribal urban sponsorship is the purchase of health insurance coverage on behalf of tribal members or other IHS eligible persons. And so today we'll be talking about maximizing opportunities under the federal marketplace, federally established marketplaces, established under the Affordable Care Act, but also there's opportunities for sponsorship that tribes and urban programs can do under Medicare, Part B, Part D. Many tribes are doing that, as well as just general purchase of insurance where that might be beneficial even where there's not federal funds involved. Two specific goals of sponsorship: generate additional resources, meet the healthcare needs of tribal members, IHS eligible individuals, and secondly is make health services more accessible to tribal members, particularly in the marketplace. If you're an enrolled tribal member and you do not have any out-of-pocket costs, you can go to a provider, whether in the tribal health system or outside the tribal health system, and not have to pay any out-of-pocket costs. So for many folks, that really facilitates timely access to healthcare services without having to go through a narrow set of providers or getting PRC authorization for out-of-pocket costs. So a couple background documents to go through here. One is just the general authority to do sponsorship. And in the Indian Healthcare Improvement Act, as revised and made permanent as part of the Affordable Care Act, Section 402 clarified that tribes, tribal organizations, urban Indian organizations may engage in sponsorship, may purchase health insurance coverage with funds made available through appropriated dollars, as well as through third-party revenues that are generated, as well as other resources available to the tribes, tribal organizations, urban Indian organizations can be used for this purpose. So that was clarified. Moving here, the context of doing this presentation and others is I'm a technical advisor of the Tribal Self-Governance Advisory Committee, and there's a joint initiative between Tribal TSGAC and the Direct Service Tribes Advisory Committee of the IHS. We call it the Joint Initiative. And the goal of that is to make sure that every tribe and tribal organization, including urban Indian organizations, are made aware of that they have the opportunity, if they decide to do so, to engage in sponsorship and as a way of bringing in additional federal resources. So particularly when we're talking about direct service tribes that may not have access to the resources as self-governance tribes may have, and they're in control of IHS, or IHS's operating programs on behalf of the tribe has the ability to take some of the resources that are with IHS, such as PRC dollars, bring them over to a contract, set up a tribal sponsorship program, and sponsor members according to the eligibility criteria that are established by the tribe. So the bottom line point there is tribes have the ability to access resources that are available and bring them over to start sponsorship programs if they decide to do so. The slide here on slide 11 just shows what enrollment in the health insurance marketplaces have been over the last few years. CMS is pulling together numbers for 2018, but we have numbers through 2017 here. That in the dark blue are enrolled tribal members, and the numbers in the beige area there are for individuals who identify themselves as IHS eligible individuals. This is for the health insurance marketplaces that are established state by state for the ones that are run by the federal government. The data is in the graphic there. Down below, points out that there's another 6,100 enrolled tribal members in the states that have state-based marketplaces that have enrolled in the health insurance marketplace. So just looking at the blue real quick, going from 2015 to 16, 2016 to 17, we've seen substantial growth, 17%, 20% growth in enrollment in the marketplace by enrolled tribal members. So particularly as looking at the 2017 number, enrolled tribal member growth in the marketplace went up 20%. For the general population, growth was kind of flat from 16 to 17. So we can see that tribes are identifying the marketplace as a more and more as a place to access additional federal resources to complement Medicaid and other funding sources. Just a little bit of a broader picture here. How does the marketplace and sponsorship fit in? As you know, there's the longstanding revenue streams, so that the appropriated dollars, Medicaid and Medicare enrollment, and the ability to bill for services under those programs started in the late 70s. But the Affordable Care Act brings in new federal resources. Those come in the form of premium subsidies, so premium tax credits is the term and the method by which the funding is made available for lowering the cost of purchasing insurance. And then for enrolled tribal members specifically, there is a provision that for enrolled tribal members, when accessing healthcare services, there are no deductibles or co-payments required for enrolled tribal members. Other IHS eligible individuals do not have that comprehensive cost-sharing protection, but may be eligible for the general population's cost-sharing protections. But again, for enrolled tribal members, is a specific provision that says whether you're going to within the tribal health system, whether you're going outside of the tribal health system, enrolled tribal members are not required to have the out-of-pocket costs for deductibles or co-payments. But that one, there's two parts of that. One is the individual doesn't have to pay, but also when a IHS eligible individual goes to an urban program or goes to a tribal or IHS program, the program will get full reimbursement for that service and not have to, in a sense, eat the co-payment that's not paid by the beneficiary. So no cost for the enrollee and full payment for the tribal urban IHS provider. This slide and the next slide kind of gives a kind of broader context of sponsorship and how some tribes have moved forward with maximizing resources available under the marketplace. In the urban Indian health program context, may be a bit different, but I look forward to the discussion about that to the extent to which the environment may impact on urban Indian clinics than it does the tribal programs. What this first slide indicates is showing how funding is provided for IHS eligible individuals who may be tribal members, IHS individuals who are active users. Some have employer-sponsored coverage, some have Medicare, Medicaid, some are uninsured. You see in the gaps, the areas that have no coloring in the bar graph here represent funding that is not provided either by an employer, by the federal government, or through the appropriation. And those funds then are supplemented by the tribe, urban program, or might be paid out of pocket. So what the notion of sponsorship is to take a portion of the funds that are right now allocated to uninsured individuals, which for many tribes, urban programs, others, are insufficient to meet the full need, is to take a portion of those funds and to move them over to the marketplace. So by putting a limited amount of the funds available that are being spent on uninsured individuals, move them over to the marketplace, and in the process, bring down a whole bunch of federal funds to maximize the resources available to maximize access to health insurance coverage for the active users. So in the next slide, and there are tribes that have achieved kind of the full spectrum here of getting pretty much all their active users, their tribal members with insurance. You can see here that the example of the marketplace, some funds have been moved over there, and the tribe is pulling down now federal resources through the marketplace, through the tax credits and the cost-sharing protections. In this example, it then shows that the resources available for uninsured individuals actually meet the full needs that are there for those individuals remaining uninsured. We also see a couple other bars that are added to the graphic here on the left, which are for prevention services, and on the far right, services for long-term care and support services, which are seriously underfunded. The idea there, can we maximize coverage through the general health insurance package, bring up resources to be able to then target other needed services like prevention and long-term care services. In terms of the process for accessing the federal funds coming through the marketplace, we just start with the example here of Medicaid, and then add on the example of the marketplace. Granted, this graphic and the next slide are maybe overly simplified, but at the core, it is one additional step in the process with using the marketplace, which is not so far out of the line of what you may be doing already with Medicaid coverage. So with Medicaid, the Urban Indian Clinic would be investing to enroll individuals in Medicaid, assist them in doing that. Modest cost to do that, but it does take some effort to do that. Second, once enrolled, individuals then access services at the urban facility, at other tribal providers or private providers, and then the coverage, the Medicaid coverage, whether it's managed care or fee-for-service, pays the programs, the tribal programs, urban private providers using the health insurance coverage. Pretty, straightforward. Adding on the marketplace example, we just have one added box in there. After enrollment is the task of paying the premium that may be due. For some individuals, there will not be a premium due because their income might be low enough to have full subsidies through the marketplace. Other individuals, there would be a premium depending upon the household size and the income, what have you. But otherwise, it's pretty much the same process, assisting in enrolling, paying the premium, people accessing services like Medicaid through the marketplace. You can access services without out-of-pocket costs, and then providers getting reimbursed for those services. This graph here, when you print out your document, might be easier to read here. This is just an example of states identifying what the Medicaid coverage eligibility levels are, what it is for CHIP programs. And one point there is that the marketplace may be eligible to folks to the extent they're not eligible for Medicaid or CHIP coverage. So for adults in states that have expanded Medicaid, 138% of the federal poverty level is the general level by which individuals would no longer be eligible for Medicaid and could be eligible for marketplace coverage. This graph also indicates what rules apply in the state, and those are the rules related to contracting with health plans offered through the marketplace. Marketplace is run by the federal government. The federal rules apply, which for one requires health plans offered through the marketplace to offer contracts to urban Indian, tribal, and IHS providers. Again, health plans offered through the marketplace in states that are, the marketplace are run by the federal government. The health plans are required to offer contracts to ITUs to contract for services. The ITU is not obligated to accept that, but it was negotiated by tribal representatives so that to the extent it's beneficial, the health programs can be in-network and potentially facilitate access for tribal members when the ITU programs are contracting providers. On this slide, it's just an example of analysis that's typically done in a tribal program, and it would be similar for an urban program, where to look at doing sponsorship and might want to get an idea of how many of their active users, their patient base, might be eligible for the marketplace. On the left side, this is case study number 7, a tribe in the Midwest, 4,900 active users, of which 44% in 2015 were uninsured. So there's 2,198 individuals who are uninsured. They're the potential recipients of marketplace sponsorship. So we then looked at census data that's available on incomes for uninsured American Indians and Alaska Natives in that state. That data is statewide, though. It's not by zip code or any other local grouping. So sometimes the data is directly applicable, other times not right on for a particular tribe, and we use statewide data. But the way it shows here for this almost 2,200 individuals, we got a breakout of, based upon, again, census data, distribution of uninsured tribal members and income, how that may array. 900 roughly might be eligible for Medicaid, another 900 potentially eligible for tax credits, because tax credits are available to individuals with a certain household income, and that's between just above the Medicaid level up to 400% of federal poverty level. And they're also eligible for the cost-sharing protections. And then there's 300 to 400 individuals who may have incomes that are higher than tax credit eligibility, but if they're enrolled tribal members, they would still be eligible for the comprehensive cost-sharing protections, which is not restricted by income. We did a survey of tribes that were operating sponsorship programs. We did it through the Tribal Self-Governance Advisory Committee, and some results popped out that were pretty strong. Number one is 80% of the programs felt that the marketplace sponsorship programs was very beneficial to have. 26% of the programs felt it was not, they did not have a good experience. And so we tried to tease out what made programs more or less successful. Just run through those for a minute here. The key to positive results, number one is having dedicated staff. If you were to simply add on marketplace enrollment to the functions of existing staff, would probably have a pretty full plate as it is. Tribes were not able to maximize the potential resources available, and then in the end, it was self-defeating because the staff felt pretty much overwhelmed by just adding this function. It takes a little bit to learn the rules for marketplace, and having the time to do that right and to educate folks is critically important. So having dedicated staff and sufficient staff is critical. On the issue of having that sufficient amount of staffing, it's suggested that when doing sponsorship and the tribe, urban program, tribal organization is generating revenue, that for the first year or two, the tribe, the program, the health program, may want to look at reinvesting the resources that are generated, the net new resources that are generated, invest that back into the program to establish adequate staffing. And once adequate staffing is established, then the program can start, in a sense, spinning off the extra resources that are generated to expand the healthcare resources that are available through the tribal urban health program. So again, reinvesting the money in the first couple of years helps build the program, make it stable, and ultimately make it more successful. In a way, it's a starter business where, just as a rule of thumb, for every dollar in sponsorship and program costs that folks have, they typically generate revenues or have savings in their PRC budgets for programs operating PRC. For every dollar they invest, they typically generate that dollar back, covering their costs, plus 3 to 4 more dollars in new additional revenues coming into the system. So that would convert to a 300 to 400% rate of return for the typical sponsorship programs. So before I get off here once, just in terms of challenges to successful programs, in the initial years in particular, some of the health plans were not operating the cost-sharing protections correctly, and we still have cases where health plans are are not applying the cost-sharing protections accurately. And so that's an effort that's ongoing and can frustrate enrollees if they're ending up being charged for things that they thought they would not have to pay for. That relates to the second item there, which is something called the Summary of Benefits and Coverage document, which is something that all health plans are required to prepare, and they're required to prepare them that address the specific Indian provisions, so that if someone is American Indian, Alaska Native enrolls in the marketplace, they have available to them this document, typically 8-9 pages, and it summarizes in fairly straightforward language, how does this thing work? When would I have to pay out of pocket? What's covered? And tribal reps work with CMS nationally to add the requirement that all health plans offered through the marketplace have to create these summary benefits and coverage documents that are specific to American Indian Alaska Native enrollees. Some of those have been inaccurate, and we're continuing to work with insurance regulators and things to get those correct. But that's a point when establishing a sponsorship program. Those summary benefits and coverage documents are very helpful tools to use to educate folks. Sometimes the health plan has created them and they're inaccurate, and so we need to work to fix that. Another item there is the referrals for cost sharing and how that works. We'll talk about it in a couple of minutes, but sometimes that's been a difficult process to get in place. We've had several years now that the marketplace being in operation, tribes operating sponsorship programs. So there are models that work pretty well now on issuing referrals when those are needed. Last 2 points there, work moving through slow rate of initial enrollment. What we typically see with the marketplace versus Medicaid is that there's more upfront education required at the marketplace. It involves premium tax credit, filing taxes, using marketplace private insurance that may be more complicated than fee-for-service Medicaid. So the initial enrollment oftentimes is slower than anticipated, but once people hear there's no out-of-pocket costs and the other benefits for individuals that are have incomes higher than the Medicaid eligibility levels, it really starts to pick up speed. And then the last item there is tribes have found it very useful to make sure that they are clear on the eligibility criteria. Tribes and urban programs have the ability to set the eligibility criteria within broad parameters. Those parameters generally are limited by funding sources. So basically the number one criteria is that if you're using appropriated dollars from Indian Health Service, they need to be expended upon IHS eligible individuals. That would be the starting point. If you're using PRC funds or each funds that may be transferred over that might have restrictions on them for certain populations, just need to make sure that those align. But in general, urban and tribal programs have great flexibility in their eligibility criteria for who they're going to sponsor. But it's really important that that eligibility criteria be clear and be known so that it's applied consistently and there's not concerns about how that is done. Erica, is there any questions at this point? We could turn to those.
We have no questions at this point.
Okay. So if any pop up, I'll go ahead and just keep rolling through. If any questions pop up, just let me know. We can address them. So on slide 17 here, moving on slide 18, or talking more broadly, not just about sponsorship, but about the opportunities and requirements under the Affordable Care Act more generally. So as you know, the Medicaid expansion under the Affordable Care Act, states ultimately had it as an option and not a requirement. And so we have great variance across states in terms of the expansion. Right now, there's roughly 120,000 IHS eligible individuals that do not have Medicaid coverage, that if all states were to expand Medicaid, they would likely pick up coverage. That's a substantial number of individuals. The latest numbers from the Congressional Budget Office is that the average amount of spending for individuals enrolled in the Medicaid expansion across the country averages $5,600. So on average, Getting someone enrolled in Medicaid under the expansion has generated $5,600 in payments out to healthcare providers. So it's a really critical source of revenue coming in through the system. With the health insurance marketplace, as pointed out, premium tax credits that are available are constrained by household income. So for the purposes of the marketplace, if you think of a tax household, when you file your taxes, who's ever included in that tax filing, that would be a tax household. That makes up the base for determining the income by which the premium tax credits are based. And so that's, again, between 100 and 400% of the federal poverty level is the band for eligibility for tax credits. Family of four, about $98,000 a year. For an individual at 400%, that's roughly $48,000 a year for eligibility of tax credits. The Indian-specific cost-sharing protections that I mentioned is not limited by income. So whether you enroll in the marketplace and are not eligible for tax credits, but you're an enrolled tribal member, you can still access the comprehensive cost-sharing protections. To just provide a couple examples here of if an individual with the characteristics indicated in the slide were to enroll in the marketplace in different areas of the country, what would the costs look like in terms of premiums, who picks up those costs, the enrollee, or the urban program, or the tribal program on behalf of the enrollee, or the federal government? How does that work? So we've got a couple examples, different locations in the country, and also different household incomes. So the first example here is a single individual, one-person household, who has an annual income of $18,000 a year. Their income is just above the Medicaid eligibility threshold, so they may make $10 an hour full-time for this example here. So you can see by the number at the bottom, $5,179, is that in Gallup, New Mexico, where this individual resides, this individual in this case is 40 years old. If they were to enroll in the marketplace, the health plan there, in this case it's Blue Cross Blue Shield, estimates that 40-year-old individual on average will have about $5,100 in health care costs in a given year. Some of those costs are covered by the premium, and some are covered by the out-of-pocket costs that an enrollee might have. So we see in the graphic there that the base of the bar graph there, $3,378, is the premium for that individual to enroll in the marketplace in a bronze level plan. Bronze level plan are the lowest cost plans because they have the highest out-of-pocket costs. And so the plan premium itself picks up a lower share. With American Indians, Alaska Natives, they're encouraged to enroll in the bronze plan if they're an enrolled tribal member, because it keeps the premium lowest for the enrollee or the tribe or urban program sponsoring them, and has the highest out-of-pocket cost. But in this case, the out-of-pocket costs are being picked up by the federal government. So it's a way to minimize the expenditure for premium costs for the sponsoring entity, maximize the amount of funds that the federal government is kicking in for out-of-pocket costs. So that's why bronze enrollment is generally suggested. Having a little issue right now with something popped up on my screen. There we go. Okay, sorry about that. I'm back in business here. Okay, so single individual lives in Gallup, New Mexico, enrolls in the marketplace. The premium for that individual will be $3,378 a year. As shown in here, the federal government would contribute that full amount, cover 100% of the premium. The second part there is the typical out-of-pocket cost, the average out-of-pocket cost that an individual might have. And that is shown here as based upon the health plan premium. About $1,800 a year is the average out-of-pocket cost for someone enrolling in a bronze plan in Gallup, Mexico in the marketplace in 2018. Because this is an enrolled tribal member, those out-of-pocket costs are picked up by the federal government. So the out-of-pocket costs are picked up by the federal government. The premium through premium tax credits are picked up by the federal government. So enrollment of this individual who's not Medicaid eligible because their income is just above the Medicaid eligibility level, federal government will be covering 100% of the cost of this individual's coverage, including the out-of-pocket costs. So if the tribe were to sponsor them, or the urban program were to sponsor this patient, their investment would be assisting the individual to enroll, and there would be no cost to the urban program for the sponsorship itself. We can go and look at a couple more examples here. So the example here in North Dakota, in Fort Totten, happens to be where I am right now. This is an example of a 3-person household, annual income of $45,000 a year, so kind of right at middle income. All three are, in this example, are enrolled tribal members. The figure down at the bottom there, total funding, $17,283. Again, based upon the health plan's premium offering, $17,000 plus is the amount of healthcare expenditures that a family of 3 is expected, based on experience, to generate in healthcare costs, healthcare funding in 2018. So the way that's broken out, again, we have the premium component, we have the out-of-pocket costs. For the premium, you see that $10,685 of the total premium would be picked up by the federal government through tax credits, and $587 would be the enrollee obligation, or in the case for sponsorship, an urban program or a tribal program would pay $587 to sponsor them for the premium. The out-of-pocket costs, which are substantial, the average out-of-pocket cost for bronze plans, over $6,000. Those costs would be picked up by the federal government. So to sponsor a middle-income family, $45,000 a year, 3 persons in the marketplace, would have a net cost to sponsor them of $587 a year in Fort Totten, and the federal government would be picking up the remainder of the cost. Just a point about the subsidies for the premium tax credits, those are paid out, the premium subsidies, the premium tax credits are paid out monthly by the federal government directly to the health plan that the individual enrolls, so that there's no delay. It's not that the individual pays and then gets reimbursed. The health plan gets paid throughout the year with those premium tax credit payments out the door. In our final example here, I believe, a 4-person household in Maricopa, Arizona. Maricopa, just outside of Phoenix there. And for this 4-person household, 375% of the federal poverty level, a little over $92,000 a year. They would be eligible for tax credits, and back the family would generate just under $15,000 in premium subsidies tax credits. To sponsor them, or for the individual family to pay on their own, would be $1,800 for the year. So roughly, $120 a month to sponsor this family of 4, making $92,000 a year. Federal government pick up the rest of the premium. Out-of-pocket costs shown there would be, again, picked up by the federal government, with the assumption here that these individuals are enrolled tribal members. Again, other IHS eligible individuals that are not enrolled tribal members may be eligible for the general cost-sharing protections, which go up to households with up to 250% of the federal poverty level. So for a family that's over $90,000 a year, the federal government would be picking up 93% of the costs for their coverage in the marketplace, assuming eligibility for the tax credits and eligibility for the out-of-pocket protections as being enrolled tribal members. On the next slide, and I usually just have one of these slides in my presentation, but I went ahead and put 4 or 5, 6 of these slides here. And what this slide represents is, if we were to kind of get a picture of different household sizes, different household income levels in different locations around the country, each slide being a different, typically a different location, what would the premium cost be to a sponsoring entity? And so as a starting point, might have a urban program, doesn't have a whole lot of extra money laying around, and might want to start a sponsorship program and might say, well, let's say I've got $50,000 for that I've been able to free up from third-party revenue, or I got a dedicated funds coming over from IHS, or I negotiated with the IHS hospital in the region that I want to start a sponsorship program, and I'm going to enroll folks so when they come to the hospital gets revenue, just like the urban clinic will get revenue. Wherever the $50,000 is generated, urban program might say, okay, I've got a number of uninsured individuals that are working hard, making an income. Their income's above the Medicaid eligibility level. Their employer doesn't offer coverage. How can we help them out? Does a sponsorship program fit into our mix? This table helps guide what might be the eligibility criteria that a urban program might apply at the beginning of its initiation of a sponsorship program. It might say, I'm going to cover people that are just above the Medicaid eligibility level up to a certain income level initially, so constrain who's eligible. But when I do my assistance to see if they're Medicaid eligible, if they're not and their income is a bit above it, I'm going to sponsor them in the marketplace. And what I want to do is set an income threshold above Medicaid to some level of federal poverty level where the sponsorship costs are really moderate. So if we were to look on this table here, again for Maricopa, Arizona, we see that right around 225% of the federal poverty level, so that was the family of 3 to 45,000. We see that from 225% and below, these families, there is no premium cost because the premium tax credits are sufficient to cover the costs in the program and in the marketplace. So if a urban program were to start a sponsorship program and say, I'm going to sponsor people that are just above Medicaid eligibility income threshold up to 225% of the federal poverty level, that's going to be my target in year one, and we're going to see how that goes. And we have a limited amount of resources, so we're going to limit our enrollment to a fixed number of people or just until the 50,000 runs out. When you enroll someone, you need to project the expenditure for the full year, but you have that 50,000 budget. However you want to set your eligibility criteria, you might target it, again, for those between 139 and up to 225% federal poverty level. Most of those folks, there actually won't be a cost for premium subsidy because the premium tax credits will be adequate. So you'd have all the individuals in those categories enrolled at very modest cost to the urban clinic, but bringing in full coverage. To the extent they're enrolled tribal members, there would be no out-of-pocket costs for those individuals. So an example often used with tribal clinics is someone may be coming to the clinic and they need a test such as an MRI. Looked on the schedule the other day for Medicaid reimbursement, $960 for an MRI was one of the rates, depending on the type of MRI. So rather than refer somebody out and paying $960 for an MRI, that $960 could be used to purchase insurance for that individual and maybe others to the extent there is no premium for comprehensive coverage for the whole year rather than getting that one service. Or whether the service is provided at the clinic without compensation, it's still cost incurred. If they were to enroll that individual in the marketplace, they'd be able to get reimbursement. They have those testing facilities or what have you at the urban clinic itself. So again, we've got different examples here. The net cost varies by area around the country because of the way the tax credits are calculated based upon the silver plan and the plan that you enrolled in. And the silver plans are all health plans across the country are priced differently. So each of these tables are a bit different, but they all tell a similar story that right above the Medicaid eligibility level up to somewhere middle income, there's very low premium cost to sponsor individuals. Many tribes, though, have sponsorship for individuals up to 400% of the federal poverty level. Some don't have an income limitation. depending upon what the particulars are of the tribal program they do that. So the example here, Maricopa. In the next slide, 27, we've got Apache County, Arizona example there. The next one is in Montana, just outside of Billings in Bighorn County example. In this slide on 29 versus 28, which you just looked at, they're both Bighorn County. I think I've got it right here. It's the example here is whether the enrollment is in the lowest cost bronze, as shown on page 28, or whether it's in the Blue Cross plan, that's shown on 29. So we can see that there's a difference on the impact of the net premium cost depending upon which plan you enroll in there. Some may find that if they're living in the Billings area there, slide 28, that's a plan that's an HMO. It may need to meet the need of the tribal member. Others may want to enroll in the Blue Cross plan, which in Montana has greater network of in-network providers. Just the point there, though, that the cost-sharing protections apply both in-network and out-of-network. So different considerations is shown here on slide 28 and 29 about what plan you pick as the preferred plan impacts the net premium costs that the urban program, tribal program might have to sponsor the individual. Here's a Gallup example, and that example there of Benson County, North Dakota, and this one is Kay County, Oklahoma. Santa Barbara, we've got an example here in California. Two examples, I believe we've got this one example there with California, which looks very similar to some of the earlier ones in terms of the distribution of the net premium cost. Let's see if we want to. We just talk a little bit about the cost-sharing protections and how those work. So as I indicated several times, there's comprehensive Indian-specific cost-sharing protections that are available for individuals that are enrolled tribal members. Within that protection, there's two types, one called zero and one called limited. The zero cost-sharing variation has an income threshold of between 100 and 300%. If the household income is between 100 and 300, and they're an enrolled tribal member, they would get the zero cost-sharing variation. If their income is outside of that, or they're not eligible for tax credits, they would get the limited cost-sharing variation. The difference between limited and zero is that for the zero cost-sharing variation, if you're getting care within the ITU system or getting care outside the ITU system, cost-sharing protections work the same. There's no paperwork required to get the cost-sharing protections. When you go to the provider, typically indicated either on the card or electronically to the provider that there's no cost-sharing for this individual because of the plan they're enrolled in. For those in the limited cost-sharing variation, their income is either above or below 100, 300, or they're not eligible for tax credits. They're eligible for the limited cost-sharing protection. What that means is when they go to a tribal program, urban, an ITU program, the health plan will pay full without any deduction for cost sharing. So there's no cost sharing in the tribal health system. When someone, an enrollee, goes outside of the ITU system, they too do not have out-of-pocket costs, but they need a referral from the tribal health system to get the cost-sharing protections outside of the tribal health system. So there's different approaches that have been taken to facilitate issuing those referrals, so at least bureaucratic. But that's the big difference. So when you go outside the tribal health system in the limited cost-sharing variation, there is paper required to get the cost-sharing protection. Eric, maybe I'll turn back to you to see if there's any questions at this point.
We had only one question, which we were able to answer while you were presenting. There hasn't been any additional questions at this time.
Okay, great. Given a limitation on time, let me I'm going to cut over a couple of the slides and just highlight a couple points. On the, I'm sorry, I'm going to go back couple slides here. I've got to add order one sec. So one thing I want to point out is eligibility criteria for the premium tax credits. And so they're listed here. One is general eligibility for the marketplace, and it's pretty much you need to live in the state for which the marketplace is based, and need to be in the country legally and not be incarcerated. The next set is eligibility for the tax credits specifically. In addition to the general eligibility requirements, you need household income, as I mentioned, between 100 and 400, and also not eligible for Medicare or Medicaid, but also not have an offer of coverage elsewhere, which is basically not have an offer of employer-based coverage, either through your employer or through a family member's employer. So if your spouse is employed somewhere and that company offers coverage to your spouse as well as yourself, that makes you ineligible for premium tax credits. Still could have eligibility for the comprehensive cost sharing as an enrolled driving member, but that makes you ineligible for premium tax credits. So that's one area to look at when you're looking at who may be eligible for sponsorship premium tax credits, which if you condition sponsorship on individuals eligible for tax credits, that will eliminate some individuals that do have marketplace coverage offering that they might not take and may not want to pay for it, but that would exclude them from that. A couple points here about benefits from sponsorship. Overall, generating greater resources, and that's in three areas. Number one is revenue right to the urban program and other Indian healthcare providers. Two, savings in PRC programs to the entities that are operating PRC program. And then third is expanded access to healthcare services. Many individuals, beyond something that might be funded by a PRC program, may be able to gain access to services that would just never be funded by a PRC program because they're not covered in the priority system of that PRC program. In addition, by doing enrollment in marketplace, like enrollment in Medicaid, is that the tribal member ends up with reduced costs. Oftentimes, there are costs that are not picked up by the clinic, by PRC programs, what have you. And so those are covered in the instance of both Medicaid and the marketplace. And then finally there, the point being that with the IHS appropriation, it's a finite amount of money, typically insufficient to meet the healthcare needs of IHS eligible individuals. By moving into the marketplace, we're able to spend a finite amount of money to get health insurance coverage, which covers all the medical needs of that individual. So we've got generating what we might refer to as a mini entitlement. We move from fixed dollars over to buying the health coverage, which creates mini entitlements for all the healthcare needs that the individual might have. So I want to jump ahead, Eric, a little bit here. I'm going to go to slide 35. My numbering is off a little bit here. Slide 39, which is some financial results from marketplace, from a sponsorship program in the marketplace in Alaska. I've had the pleasure of working with the folks in Alaska since 2013, setting up the program. And they're allowed me to share their financial results from the first 18 months. They've had several 18 months period since that time, and the results have even grown stronger. The particulars about Alaska, the costs are higher and things of that sort up there. So that's kind of unique to Alaska. But the net results that I'm showing on this slide here have been replicated by a number of tribes that I've worked with in the lower 48 states. What we're capturing here in the table is actual cash coming back into the program itself. So these are revenues generated for the tribal health programs in Alaska. In Alaska, about 80% of the tribal members are represented in the statewide single sponsorship program that they have going there. So over the first 18 months, we look at the far right bottom line, there's a net financial gain of $6.3 million by the enrollment of 896 individuals over the first 18 months. So that was enrolling individuals running the program, paying the premiums, the net gain after covering all the costs was $6.3 million net gain. And that's broken out by two groups, the group of folks below 138 and above 138. At the time that the first 18 months, the Medicaid program had not been expanded in Alaska. So it subsequently expanded it, and the individuals 138 and below who were on sponsorship moved over to Medicaid. But at this time, most of the individuals at 138 and below, the tribes were actually paying full premium without tax credits because individuals under 100% do not get tax credits. So even with the population there, they were able to generate 6.3 million net revenues coming to the tribal programs. On a percentage basis, 294%. So a return on investment. Basically, they got the dollar back for every dollar they spent for premiums and running it. They got the dollar back and just shy of another $3 to the program. That's cash. In addition to cash coming in as revenue to the tribal health programs, there were savings because PRC expenditures were not required in many instances. The precise amount is not exactly certain. We know that $1.5 million was spent by the health plan for those 896 individuals, was spent to private providers. Whether all of that would have been PRC expenditures, approved expenditures, it's uncertain, but the majority of that would have been. So in addition to 6.3, there was $1.5 million in benefit coming in savings, potentially some amount of $1.5 million in savings to PRC program. Beyond that, there could have been health services that were secured as well that would have not been eligible for PRC that were covered by the health plan. So that's an example of the financial benefit. For programs, an urban program that sets up a sponsorship program, their services compared to, say, the Alaska example, which has the full range from tertiary care to primary and preventive services, might be narrower. So the revenue coming back to the urban program and setting up a sponsorship program, you might want to look at what would be the amount of revenues coming back into us specifically. Also might want to look at, our patients go to, say, IHS or tribal facilities as well, or referred out, and might have rough numbers on the benefit then would go to the other Indian healthcare providers in the area. Maybe an opportunity to collaborate with those healthcare providers to indicate that if you were to do the effort on sponsorship and enrolling people, they may cover the cost of doing that because they're going to be generating a lot of additional revenue coming into them as well. And then there's the issue of PRC savings, which would be there for, may not be for the urban program, might be for the other, again, Indian healthcare providers. But the bottom line there is these individuals that you might sponsor, even if the amount of revenue coming directly back to the urban program might be limited by the scope of services of the urban health program, that individual would have access to comprehensive services wherever they go. And so at a modest effort to get folks enrolled would be bringing great benefit to the urban Indian clinic patients who would have easier access to the healthcare services. One last point, typically when a program establishes a tribal organization, a tribe or what have you, establishes a sponsorship program, they typically enter into a contract, a little agreement, one-page agreement, what have you, with the enrollee, where it specifies, here's what we're going to do, we'll pay the premium, what have you, here's what we expect you to do, continue to use our clinic, and whatever rules you want to put in place as part of that agreement, so that it gives the sponsoring entity control over how the program is going to work and set whatever rules are most beneficial for the individual as well as for the Indian health program, the urban Indian health program there. So that's a lever that versus if someone were to enroll in Medicaid, there's no contract in that case. The Medicaid recipient can go anywhere they want without constraints. With the sponsorship program, the tribe urban program could, like tribal programs do, direct people to the individual retaining, using the clinic for primary care using the clinic for pharmacy services or whatever may be offered by the urban program. So, Eric, I think I ran a little bit over time, but if there are any questions, I'd love to answer any questions. On the front of the presentation is my email address, and anyone that has questions beyond what you might have here, feel free to send me a note and I'd love to answer them.
Okay. We don't have any questions in the queue yet, and I think that maybe some people probably want to digest. There was a lot of information they received, so they probably will be following up a little later. But I want to thank everyone for joining us today, and many thanks to Dominic Madonna. Truly appreciate the wonderful information you provided for us today. Once again, the presentation slide deck is going to be available as a PDF. It's located currently at the bottom right-hand corner of your screen in the presentation slides and handouts. We will also be sending that out with the notes after the webinar. We ask that you continue to watch out for other upcoming NCUE-sponsored webinars throughout the NCUE website, which is www.ncue.org, or our e-newsletter. We ask that you take a few moments, please, to provide feedback on today's webinar through the SurveyMonkey link that was now located inside your chat box. We will also provide this link through a follow-up email along with the recording of today's presentation. As always, please feel free to contact us or to contact the presenter with any questions you may have. And thanks for attending today's webinar. Please take care and have a great day.